And then you can also see with the key on the left, we've have a notation where it is an expansion renovation project. So you can see the difference there and where they are located. Significant planning and construction are underway for the new facilities. Our staff and our contractors are working to build state-of-the-art facilities and modernize older buildings, ensuring a more therapeutic and safe environment for our patients statewide. On slide 4, we provide a timeline where we anticipate HHSC operated in our contracted hospitals will open. We're pleased that most of these projects will be completed during the next biennium and allowing us to serve more people in need. Mr. Chairman, I would like to thank you and the legislature for your investment in these projects. HB 1 as introduced includes funds needed to operate our state facilities that will come online during the next biennium. I look forward to working with this committee on funding for the facilities that we have contracts with. Facilities like Texas Behavioral Health Center in Dallas, Sunrise Canyon in Lubbock, our new hospital in Rio Grande, and the resources needed to complete construction of the El Paso Psychiatric Center. The following 2 slides, 5 and 6, compare the number of beds before construction began and shows you what the new capacity will be once construction is complete. State 5 is our state-owned hospital capacity, and State 6 outlines our partner contracted capacity. Although the post-construction capacity will be lower for some hospitals, you will see that, we will not be serving fewer patients. Instead, we are increasing our overall capacity by building more hospitals throughout the state and renovating those that sorely needed it, which ensures people can access inpatient services closer to home. The remaining slides present data on the number of beds we have online currently, as well as the forensic waitlist figures. Slide 8, you will see that we've made significant progress in reducing the number of people waiting for a maximum security bed by almost half. Slide 9 shows the non-maximum security forensic waitlist. While the waitlist hasn't dropped much from July 2023, it has dropped drastically since our high waitlist number in 2022, which was 2,571 people. This concludes my presentation. I want to thank the committee for the opportunity to provide this update on our facilities, and I'm happy to answer any questions you have at the appropriate time.
Chairman Bonin, Vice Chair Gonzalez, and members, and for the record, my name is David Lakey, and I currently serve as the Vice Chancellor for Health Affairs, and I'm the presiding officer of the Texas Child Mental Health Care Consortium. Thank you for this opportunity to be here with you today to discuss the consortium. You have the slides. I'm going to go through them very, very quickly, put many of them in the appendices so you can look at some of the data, and we'll hit the high points related to the consortium. For the new members, on slide number 2, I have the background related to the consortium. This was a bill that was brought to the legislature in 2019. Thank you, Chairman Bonin, for your work related to this bill. But the goal is to bring together the medical schools across the state of Texas, working with the state to improve the care of mental health, behavioral health for our kids across the state of Texas. Some of the funds were through GR, some of the funds are through ARPA. On slide number 3, you have the breakdown of those funds. On slide number 4, you have the organizational structure, a couple of key points. It has all the medical schools. At that time, that had the departments of psychiatry working together with state agencies and the philanthropic organizations involved in mental health. The funding comes through the Higher Education Coordinating Board, but the University of Texas system was asked to be the administrator of these funds. In order for us to do this effectively, we have a contract that we call the Centralized Operating Support Hub at Baylor College of Medicine. Dr. Laurel Williams is sitting behind me. She is the medical director of the consortium. I am not a psychiatrist, and so I'm reliant upon the psychiatrists across the state to guide us in this work. On slide number 5, you have the core programs related to the consortium. All of these work together in concert. Basically, the strategy is that we don't have enough psychiatrists here in the state of Texas, especially related to child and adolescent medicine. And so we need to leverage the skills and the assets we have. We need to support the primary care providers and then use technology to be able to provide services. At the same time, we build the workforce here in the state of Texas. And so the first program and the biggest program is called TCHAT, the Texas Child Health Access Through Telemedicine. This is school-based telehealth. It's designed for short-term care to identify the kids in trouble. And so if a counselor or teacher has a child that they think is in trouble, they refer it over to TCHAT, and for free, the state provides the analysis, the care for the child. And the goal is then to hand that child off to another provider in the community. The challenge is that's hard, that we don't have the mental health providers across the state of Texas. And so a lot of times we're holding on to those kids a little bit longer than we initially desired to. We do measurement-based care. I underline parental consent, and this is very important for the consortium. We do this many ways to make sure that parents are involved in the decisions related to the consortium. Some of the projects have been funded by ARPA. It allowed us to expand quicker. It allowed us to provide additional care for kids beyond initial 5 services. Again, ARPA dollars are going away, and we've been growing significantly over this time period. On slide number 7, especially the process, we have to do a lot of work to establish MOUs with school districts across the state. We then have to onboard the schools. There's several steps in order to do that, put the technology in to educate the liaisons, and then to provide the services. And again, the liaisons identify kids, we get parental consent, and then we provide those services. On slide number 8, just a couple of the data points right now. We've rolled this out so that we're covering 4.3 million kids across the state of Texas. That leaves us about 13% of the student body that now does not have that service available. That's 911 school districts, over 7,000 campuses. We've seen incredible growth. I have slides in the appendices that show the year-over-year growth. Last month, we saw, we're seeing right now, we're having referrals of about 5,000 kids a month being referred. It goes up and down depending on the season. Again, we're seeing 25 to 30% growth, had over 88,000 referrals, 44,000 students, over 237,000 sessions that have been provided statewide. A lot of the reasons the kids are referred is because of anxiety, depression, but then there's some kids that about 14% had suicidal concerns, 11% had self-harm, 7% had significant bullying, and that's why they were referred to the program. We survey parents, and you have some of that data on slide number 9, to make sure that they believe the service is of value. 91% of parents believe that they were satisfied. 86% believe that the child was better. I have some challenges listed on slide number 10. I think basically it's the challenge of rolling out a big project across a very large state quickly. And so recruiting staff from across the United States to come has been a challenge. One of the big challenges is, again, the referral. After we've had a child and he or she needs continued care, who do you hand that child off to for the long-term services? And looking at how can we learn from one another and be more cost-effective in the services? Second big program is called CPAN. Basically, the way this works is if you're a pediatrician, there's a child that's in your office, you don't know exactly how to care for this child, pretty much immediately you can get a hold of one of our child and adolescent psychiatrists at one of our medical schools across the state of Texas. And when I say immediately, we have a key performance measure of, did the call occur within 30 minutes? 98% of the time it did. If you look at the median time, it's less than 5 minutes. And so while that child is in the office with a pediatrician, they can talk to a specialist to guide them how to take care of that child. And then a lot of work takes place to link them to services. Last month, in January, 1,678 consults were made across the state of Texas through CPAN. So a couple of the other data points you see in slide number 12. We have 14,000 providers across the state that are enrolled, a little over 3,000 clinics now that are enrolled, and you can see the total number of consults and the patients that we serve. And we do continuing medical education, trying to build the knowledge, capacity, skills of the pediatricians, the family medicine doctors across the state. So in slide number 13, a couple of those challenges, the ongoing need to reach out to the pediatricians, making sure that we do this as user-friendly as we can. When pediatricians are very busy, they don't have a lot of time to wait for somebody, and so how do we use technology, et cetera, to be as user-friendly as possible, and trying to coordinate across our 12 HRIs, figure out how there can be synergy. If one HRI is backed up, how can we use another HRI to fill in during that time period so we can make sure that we're answering those calls as quickly as we can. On slide number 14, we have another program that was developed with ARPA funds. It was a need from the state of Texas as identified by the Texas the Maternal Morbidity and Mortality Task Force, that we need to provide mental health support for the OBGYNs across the state of Texas. And that's what we've tried to do with PeriPan. And so it's basically the same thing with a CPAN, except for OBGYN providers across the state of Texas. We did a pilot program, worked out the issues, and then have gone statewide in September of 2023. You can see on slide number 15 some of the data points. Last month we did 205 consults across the state of Texas. We've done over 2,000 total consults. And again, a lot of this is referring individuals, trying to find somebody that'll provide ongoing services for the women. Some of them are pregnant, some of them are postpartum. There's a variety of mental health issues that we can, by linking them to the right person, help them get the care that they need. This is, again, was an ARPA-funded project, so it's currently, the funding is not in the budget at this time. The next project is, we call it CPW. Basically, it's a community psychiatric workforce expansion. Basically, the goal here is to get our psychiatrists into community public mental health service earlier on in their career. And when they do that, they're more likely to go and work at a community mental health center in the future in their career. And so we put an academic psychiatrist and residents with them in the local mental health authorities. And with that, a large number of individuals have changed their career plans. That if you look at the data in El Paso, none of their residents would go into child and adolescent psychiatry. This last year, 5 of the 8 decided that we're going to go into child and adolescent psychiatry because it changed that environment in which they were learning to take care of kids. And you can see some of the numbers there on the total number of encounters. Another part of how we're building the workforce is investing in child and adolescent fellowships in the state of Texas. When we started this program, there were 27 first-year slots across the state of Texas. There are now 46, so we had about a 70% increase because of your investment into these programs. We were also able to establish 3 new programs that you have listed there, and you can see the continued growth of that program. So thus far, there's been 74 individuals trained through the consortium, and so between 2021 and this year, 209 new fellows have trained in the state when you look at previous programs and those that have been provided by the consortium. The other part is trying to figure out how we can be smarter with delivery of mental health services here in the state of Texas. And so we have a research initiative. Research may be the wrong word because it's not bench research. It's not pharmaceutical research. It is looking at the systems of care and the gaps of care here in the state of Texas. What do we need to know to be smarter in the delivery of mental health services here in our state? And so we have 2 large studies, one looking at kids with significant depression, one that looks at kids that have significant trauma and looking at the gaps in their care and what we could do to be smarter. We've also invested in young investigators this year, and we worked with HHSC to identify what they thought needed to be evaluated in the state. What programs are we implementing that it'd be nice to have better data about? And so use that as the guidance to be able to invest in young investigators and so they could start their careers. 3 other programs that are supported by ARPA, and make sure you're aware of. One is Youth Aware of Mental Health. It's an evidence-based interactive mental health prevention program for 8th through 12th graders. Again, I'm not going to read the slide to you, but there's been almost 52,000 eligible students that have received that service since we began that with ARPA funds. And then the last 2 on the slide number, slide number 20. One is pediatric collaborative care. Basically, the goal here is to integrate mental health services into primary care and do that in a way that's sustainable, and so that they can bill for those services on an ongoing way. And after the training, the development of the services, then they can be sustainable with those ongoing services. And then workforce development. We have talked many times of the need for additional mental health providers across the state of Texas. If you look at the federal data, pretty much the state of Texas is a health professional shortage area related to mental health. And so with the ARPA dollars, you allowed us to invest in training programs for individuals that aren't psychiatrists. And so psychologists, social workers, other counselors, these are individuals that are fellows, interns, practicum students. I was up at Lubbock last week and met several individuals that were actually providing services and now are on the faculty because they had been trained there. They'd come from across the United States, had a good experience at Texas Tech Health Science Center, and are now part of the delivery program there, providing not only programs of the consortium, but other mental health services up in that community. On slide number 21, you have the budget. You have the HB 1, how it was introduced, what our request is. Again, the main difference is the request for programs that have been funded by ARPA and have been proven to be successful in our eyes to make sure those are sustained. Peripan, the YAM, collaborative managed care, and some of the extended TCHAT services because, again, the difficulty of handing off children and, again, trying to move from being available in 78% of all the schools to all the schools that want this program. The other thing that we see is after we're in schools, year-over-year growth. As the schools become accustomed to this program, they're much more likely to refer to the program. And the final slide, 22, just has some considerations. Again, things that I've talked about before, the ARPA programs and making sure that we have the authority related to that, but also the fundings to continue to provide those services. We think there's opportunities to combine budget authority between CPAN and TCHAT, which would include some efficiencies, and the other workforce challenges we have of the state. And the last item that I would highlight is, again, this isn't working in isolation. We really need strong community mental health services across the state of Texas because one of our challenges is handing these individuals off to a local mental health authority or other community provider. Until that is totally solid, the kids will be backed up in our service because we decided we're not going to drop kids if they need continued services as we continue to work to try to find an ongoing provider for them. And with that, Chairman, that concludes my testimony.
All right, Representative Jones.
Just real quick, one, thank you so much for the presentation. I just wanted to go back to the costs related to the mental health hospitals and wanted to see if operating costs are included in the base budget ask.
Yes, sir, they are.
Okay. Thank you so much.
All right, Representative Rose.
It's a ghost in here. I am not pushing this button.
Representative Berry.
Thank you, Mr. Chairman. Thank you all for the information. It's very helpful. I just have a few questions here. I wanted to ask, you talk a lot about students and outreach and things of that sort, and some of the issues that I've seen in our schools is that when our schools would refer a child out from the school, they would never go. So is there some way that we address that issue currently in one of these programs?
I think that's part of what we're trying to do is to make it very convenient. It's hard if you're in rural Texas and you have to take time off, mom and dad, child out of school, drive to one of the major metropolitan areas and get services. That's a whole day. What we're trying to do in several of these programs is make it much more convenient for the child to get services in their community. And so with TCHAT in the school, you know, the teacher finds out that there's a challenge and then refers, and we get these children in quickly. Now, in one of the slides, you'll see the drop-off between referrals and enrolled. And there's about a third of those kids that are referred that don't get enrolled because we try to reach out to the parents and we can't contact them, or they may have another provider. And so that's an ongoing challenge for us. And I think that's also part of CPAN. People trust their pediatrician or their family medicine doctor. And so instead of being referred to Houston or Dallas, stay in the primary care home and get that kind of support by phone to them as long as the pediatrician is comfortable, because they're going to trust that pediatrician more than the big city psychiatrist.
I got that. So, Michelle, in part of your presentation, you talked about state-owned hospitals and partner-owned hospitals. Can you explain partner-owned for me?
Of course. The appropriation that we received last session was specifically to fund some of our partner hospitals. That means that the funds flow through HHSC, and we help with the construction, but there is a partner that operates the facility. And those are Rio Grande, Montgomery County Inpatient Facility, Victoria County, and Beaumont Baptist.
And that seems to have been a pretty successful process for y'all.
It has. We have the Dunn Center operating right now, and it is successful. We are looking forward to working with those partners on their builds.
And I would assume that the state-owned hospitals, the state operates those hospitals?
Yes, sir.
Okay, just trying to define the distinction there. And so with our local mental health services, what happens when they run out of funding? How do we provide care?
Our local mental health authorities have several means of finance from us. I am not aware of any that have run out of funds to serve their clients. If there is an issue with funding, we do look at possibly shifting money from a local mental health authority that may have a little bit left over at the end of the year, or we have in the past tried to supplement with other block grant. That's a federal mental health block grant that we have if there is a gap to be filled.
So either take money that's already been allocated to other locations and move that to a location that would otherwise need it. Right?
It's rare that we have to, but that is an option we have, yes.
I understand. And so for a county that doesn't have any beds associated, like my county doesn't have any beds, but we have agreements, but just for the overall group, how do we provide services to those? For counties that don't have beds, how do we provide services to those counties?
If there are, there's two ways. One would be through our state where we do have a children's bed in our state hospital system. We have 181 across the state. It's, of course, preferable to keep a child in their community and with their families. We also have, through our local mental health authorities, contracts where they can flex between adult and children's needs. So certainly that local mental health authority in which your county is in the catchment area would certainly do their best to use one of their contracted beds to make room for a child.
And I would assume any of the beds per se are Medicaid funded?
We have a combination of general revenue and block grant funds that go towards community services and hospitals. The contracted beds through the mental health authorities do have GR funding.
Okay, and for inpatient stays, do you have any idea? I know we're going to get some of that later, but do you have any idea what the inpatient stay amount is that's reimbursed?
Yes, we have, for the local mental health authority beds, we have a cap on $800 per bed per day. They absolutely negotiate what is an appropriate market rate for their catchment area.
I got you. Thank you.
Yes, sir.
Representative Kitzman?
Chairman, and thank y'all for being here today. This is a big issue as across the state, and especially in our rural areas, as you were suggesting. We've talked about the state facilities a lot, and I'd just like to ask you a couple of questions about that. One, if we still have 519 people who are in need of a maximum security unit spot, where are they today?
They are most likely in jail, waiting for a transfer to a maximum security unit.
Okay, so not having enough facilities then creates an additional burden on our local governments, particularly our counties and sheriff's offices and jails, and that's probably not the optimum care for those folks that need it, right?
We prefer to get folks in the hospital
That's
as soon as
right.
we can.
Okay. we've talked about state facilities, but what about residential group homes, especially for people with IDD? And we referred earlier to the cap. In a state facility, that cap is approximately $20 an hour, roughly.
We have, in our state hospitals, I think we're around $1,200 per bed per day. A lot of that higher cost is attributed to the type of patient. So forensic patients, which is about 60% of our population, maybe a bit higher, does require additional staffing. Some require one-on-one staffing. And so we're serving a pretty critically ill population.
But paying those attendants you have at a state facility is about approximately $20 an hour.
I'm so sorry, I
proposing
misunderstood your
$12
question.
an hour for non-state facilities, right?
I would have to check on the, I can get you the list of the salaries for the various positions. Obviously we have the physicians, RNs, personal care attendants, so I'm happy to get those back to you.
Well, it just, we've brought it up, we've seen it in a couple of different places today, that $12 an hour, there's a very famous convenience company across the state of Texas that pays their car wash attendants more than we pay our IDD attendants in the state of Texas. And that's not a dig on you, I'm just saying we're here talking about the budget. How do we compete for the type of professionalism and skills that those people, that those attendants need in order to properly care for the people that have it, versus other competing markets that pay a whole lot more for a lot easier job. I mean, the burden's really on those folks, and I hope that this committee, among others, will take a little time to look at that a little closer this session. So, thank you very much.
Yes, sir.
Representative Simmons?
Thank you, Mr. Chairman. Good morning. So you spoke a little bit about the, issues with not enough providers. And so just had a couple of questions to want to kind of get a better foundational understanding as to why that is. Are we seeing just a national trend, or are there less people pursuing educationally and then going into these career fields? Is this like brain drain that is specific to Texas, where people practice here or study here and they want to leave? I know the need is only going to increase given a number of factors, economic factors, a toxic political climate. Children are going to continue to need these services. And I guess I'm trying to figure out what is some ways or investments incentivizing people to come actually provide these services in Texas.
I think I'll start first and then allow the other members to jump in. But I think it's a complex issue here in Texas. You know, our state is booming. You know, we're growing significantly. 30+ million individuals, and so there's the growth component. But even before that growth, we were behind. And if you look at HRSA's data, at the number of health professionals for mental health per population, we're significantly behind. I think part of it has to do with pay. It is hard to recruit young individuals if they know that certain types of stores across the state of Texas are paying more, and instead work in one of the hospitals and be, are hard jobs. These are hard jobs in those facilities. And again, I'm speaking maybe out of turn, but I'd spent 8 years at the Department of State Health Services when the mental health hospitals were there, and those were some of the lessons we learned. I think there are young individuals that are interested in these type of fields, but we need to make it easier for them to get in. I think there are things such as stackable degrees that individuals can have that can help them get into the healthcare industry. I think there's educational things that we can do. There are programs that Texas has that try to reach out to schools early on to get individuals in. I think one of the challenges, if you become if you get your master's degree in counseling, and you may be getting $60,000 on the high end, okay, but you're not at one of the local mental health authorities, and you're not at some other provider. You're going to have to pay like $5,000 a year for supervision while you're not, are not able to bill, and that's out of your pocket, and that becomes costly. And so one of the things that we're trying to do is figure out how can we provide that supervision to individuals across the state so that that's not coming out of their pocket and they can more readily come into these type of services. But there have been analysis looking at this whole area of workforce, in which part of that mental health that I'm happy to provide to you related to what people across the state of Texas thought were some ideas that we could do in Texas to bolster the mental health workforce here.
Thank you so much.
Mm-hmm.
Representative Wally?
Thank you, Mr. Chairman. Dr. Lakey, Ms. Little, thanks for, I know this has been an enormous task to kind of stand all these different agencies up to respond to the growing need, the children, but also obviously for pregnant women, the peri-pan and those programs. I want to focus on the T-Chat. Is it my understanding that local ISDs opt into this program, or how does that work so that the services are provided to the children in those ISDs?
That is correct. And so on the one slide I had, we work with school districts to get MOUs put in place.
Right.
But it's up to them. No one's going to force them. And then once the ISD is in, then the schools decide that they're going to be part of this. Some schools, some of the large school districts right now have ARPA-funded initiatives, and so they don't necessarily need T-Chat right now. Part of the concern is those ARPA funds are going to go away, and so what's going to happen to some of those school districts? But it is a voluntary process where the school district, the schools, and most importantly, the parents are saying we want this service for our child.
Because as I understand it, the Houston Independent School District, have they signed an MOU with T-Chat?
They are looking at the programs, and I can get you a list of the schools. We're in some of the schools, but not the whole schools, not all the schools in the Houston ISD.
Right, because my information says that there's only 2 of all the schools that HISD covers. There's only 2 that actually are participating in the program.
I can pull you, actually on our website, we have a map that
Correct.
anybody can go to
Correct.
your area and you can pull up the exact schools. And part of I think the dynamic in Houston is federal ARPA funds and other mental health services that have been provided. And so if they have somebody else that's there, and we support that, then that they're using that versus having T-Chat. But if those things go away, then the concern is that they may be asking for these services.
Yeah, and that's kind of my concern, is that it's one of the larger school districts. They have, my understanding, an MOU in place, and as these dollars either get exhausted or there's so many kids there that potentially need help, they wouldn't be getting help, but for the dollars running out, or we be more aggressive in HISD's case that they participate more robustly. I guess that's my my concern for moving forward, is trying to get them to participate once the dollars dry out.
Yeah. And so we are there, and if those dollars, they're federal dollars or other community dollars, go away, we would work with those schools to bring them on to T-Chat. Now it's different. This is telemedicine versus in-school type mental health services. But again, a lot of good data that the services through telehealth are very effective, and again, very convenient for the family.
Okay. In relation, Ms. Alito, in relation to the state hospitals and the expansion of all the various regions, and that I like the map's very helpful in the expansion versus new. In Houston, we're hearing from hospitals that are, from our county jails, obviously, large mental institution, lots of folks waiting to get transferred to the state penitentiary. other beds that they, forensic beds that they would have to go to. But we're hearing from some hospitals that they're having issues with an uptick of mental health patients that are having episodes where hospital staff and nurses are having to monitor these folks taking up ER beds, and ER nurses are having to, kind of triage over on the mental health side and having to do long shifts monitoring these folks that need 24-hour care. Have you heard anything of that nature from some of our hospitals?
We have, and we're all, the providers are experiencing certainly a new, I would say, a new kind of patient. Behaviorally very complex, can sometimes be aggressive, significant trauma likely in their history. And we are seeing this, unfortunately, in children, and then in some of our adults. In the state hospital system, we are equipped to handle some, more behaviorally complex patients. In our supported living centers, we are less so, but we do try where we can be the provider for those patients to do that. But we absolutely have heard, particularly from the hospitals that we have contracted beds with through our local mental health authorities, that is a growing population and one that is difficult for hospitals to serve.
Or because some of these patients are staying there days on end, waiting for the hospital or waiting for a bed to be available. Is that true?
It could be in some cases. We try also to make sure, if our local mental health authorities in particular try their best to make sure that if that child can discharge, that they have the community supports that will keep them out of the hospital. It does take some time to coordinate all of that. Some children also, unfortunately, do not have a home to go back to. And so we do our very best with DFPS, if that is the case. And if they do have a home to go back to, our local mental health authorities do a great job. Programs like multi-systemic therapy that was funded last year to expand helps wrap around that family at discharge. So we do our very best.
I want to focus my last questions, particularly for, I know we were putting resources in for the Uvalde clinic. What is it actually called? What are we calling it in Uvalde? Because I know we did a big effort to try to make sure we got resources to that community.
We did. I believe when the Hill Country, that's our LMHA there,
Okay.
is able to start seeing patients. So far, they may change the name, but so far we're calling it the Uvalde Behavioral Health Campus.
Okay. And then is that built out or is that?
The construction, we hope to be complete by June 2026. And then there's just a couple months that it takes to make sure we've got the staff in place. And so we are hoping and aiming for an opening in October 2026.
Okay. And right now, currently, many of those folks in that community are going to San Antonio. Is that my understanding?
That is correct. If we need to, we worked out a contractual arrangement so that if there is need, that there would be a bed available since Uvalde is not open yet.
Okay.
To the best we can.
Okay. Thank you. Appreciate it.
Of course.
Thank you, sir.
Representative Goodwin?
Thank you, Chairman. Dr. Lakey, on your presentation on page 22, it says mitigating and managing wait lists. I just was curious, what are the wait lists like, and how long are people having to wait for services?
So we're just starting to see this right now. We're getting kids in about 30 days after the initial referral. And Dr. Williams, make sure that I am correct. Over time, though, we've seen a couple of HRIs that had it longer wait times to get in. And so we have been working across this consortium to work as a system versus just 12 silo HRIs. And so being able that if San Antonio, for example, might be backed up, but Baylor has capacity, can we get the child, because it's telehealth, get the services from that university? And so that's part of that management, which serves individuals better, but there's some complexity there to make sure that we are handing that off. We know what the wait times are, and can find another HRI to help step in. And so you'll see, I have a map in the appendices that shows kind of the service areas, and you'll see that in some areas there are multiple colors, and there's multiple colors because there's another HRI that stepped in to help out for a certain percentage of those individuals.
And I also noticed that your budget request is, $27 million different than what's in the budget. What impact would there be if you aren't getting your request?
For TCHAT, so it would make it difficult to roll out to the rest of the schools that we want. We have, because of that lack of other providers to hand off kids to, we're holding on to kids. And so we would have to at some point say, we need to not do that. And that would be difficult. And again, we anticipate that when we're in schools year over year, you see significant growth, and especially in rural areas when there's no other provider. Once they become familiar with it, you see that growth. And so at some point you'd have to, you'd start to have a wait list, and that time of trying to get kids in would be impacted by that.
All right, thank you.
Thank you.
Representative Howard.
Thank you, Mr. Chairman. I want to follow up a little bit on Representative Kitzman, his points about how this is a burden on our local communities. I think we have to keep that in mind. If we're not providing things at the state level, it's pushing this off onto our local governments that are having to provide services, especially our law enforcement and the jail system. So I guess the question I have, and I know that this is going to be talked about in depth when the subcommittees meet, so I'm not going to spend too much time on it, but at the same time, I think there's been a lot of good questions here about the cycling that people are doing between the jails and the community, if there's a place to even go, and homelessness, and just repeating. So my question is, what is the recommendation for people who need a higher level of care than what is available in the community, those that need a structured and supervised setting, perhaps even a secure setting, and the recommendation to keep these highest needs people safe, as well as keeping the community safe, which I know is the constant problem that local communities have to balance that, keeping the community safe from those who have severe mental health issues, but also protecting those that have those issues. And how do we do that without that being the jail cell? How do we know that's a temporary fix. There's many that are in there that aren't competent to stand trial. They cannot be served by the criminal justice system. We need them to be served by the mental health provider system. I mean, there's a lot there, I'm sorry, and I know that y'all are going to be talking about this more, but just, can you respond to that just in general, what the recommendations are right now?
Yes, ma'am. We have a set of crisis and jail diversion services. Most of them are run through our local mental health authorities. Certainly being able to serve someone, and we do partner with many of local law enforcement organizations to provide a place where people can be diverted from going to jail and into mental health care. Sometimes those people do have to be admitted for an inpatient stay, but I know our local mental health authorities try very hard to manage that person. Often it's medication management, counseling. Homelessness is an issue. And so we have some of our local mental health authorities, but not all, are able to offer some tenancy supports, some rental assistance, but it's a modest amount right now that is there. But that is something that they try to work with those folks on that are in and out of jail.
So having more of those diversion programs, having more housing programs, having those kinds of things, would that help us with addressing this population?
Yes, I think being able to have more jail diversion programs, better staffed jail diversion programs,
Staffing again.
and our crisis, and that's in the local mental health authorities, and our crisis stabilization beds. That's another option, which someone could come in, stay overnight, and then be okay to be discharged. So we do have some of that in our. We are comprehending that and want to work with you all on that for 26-27.
Okay, thank you. And just, Dr. Lakey, I just want to thank you for what you are doing. And I know that mental health has been found to be one of our leading public health issues right now, especially in our youth.
Yeah.
And so whatever we can do to help our families through this, I think is going to be long-term beneficial to our state, obviously.
I agree. And for those of you that don't know me, I spent 8 years as the Commissioner of Health for the state of Texas, the Department of State Health Services, and I'm an infectious disease physician. But I came out of that experience, I think, realizing that I don't think there's a bigger public health issue in the state of Texas than the mental health system, and that we really need to address the mental health system. Because we talk about going upstream, when people don't get mental health services early on, you don't get your education. You don't have a family. It's hard to be a spouse or bring in I have a job, hold a job, et cetera. And then you have all the other infectious disease and other chronic diseases that we talk about. And so I came out of that experience being a firm believer that one of the critical things we can do to improve public health is improve the mental health system in Texas.
And I specifically want to mention Perry Pan because, as I know you know, mental health issues are one of the leading causes of maternal mortality in our state. And it's preventable. And the ARPA dollars aren't going to be there. This is a program that can help us save moms' lives, which also helps those families that have the babies and the kids have their mom there with them. So I know it's bipartisan that we support moms and babies in this state. And this is one of the ways I think that we could demonstrate that, is to make sure we continue to fund this situation that is a preventable cause of death of Texas moms. So hopefully that we'll be able to see that happen. So thank you.
Thank you.
All right, Representative Garcia Hernandez.
Mr. Chairman, first of all, thank you so much for this information. It was very beneficial. This is a topic that's very near and dear to my heart. I lost my father to suicide after he struggled with mental health through middle school and high school. And in the rural area, because we see the lack of services in the rural area in particular. So thank y'all for what y'all do. In regards to T-Chat, the 13% student lives remaining to be covered by T-Chat, what exactly does that encompass? Or is that the population of children in schools, or?
Yes. So
Okay.
we are in about 78%, covering about 78% of all the K through 12 kids in the state of Texas right now. And then you have kids that have mental health services through other funds that aren't involved and have declined T-Chat, and then that delta there that's left is 13%.
Gotcha. In regards to the workforce, is there any appetite for ideas like looking outside of Texas for people to be able to provide virtual consultations for students here in the state of Texas?
I think for T-Chat, I'll speak from T-Chat, we're trying to build that capacity within our HRIs.
Sure.
And part of that is to to make sure we know who these individuals are and to make sure they understand the will of the Texas legislature on delivery of services. I've been approached with many telehealth companies that would like to be part of this. My answer to them is always the same. I make sure I follow state contracting laws related to things. We support our HRIs as they make those decisions. But I want to make sure that if one of the HRIs decided to do that, that their counselors are of the same quality that we are hiring in the HRIs and understand the desire of the Texas legislature related to delivery of mental health services.
Of course. How about also coordination with our universities here in the state of Texas to have some of their students do some of their clinical hours and in particular serving some of the gaps in the rural areas and also the telemedicine as well?
So we've tried to incorporate training into all the programs. And so you have the workforce budget, but also in the TCHAD budget, there are students and other folks that get brought in to be part of that under the right supervision and mentorship and make sure that the quality control is there. But that's part of developing the workforce for the state of Texas.
Absolutely. Well, thank you all so much for using the ARPA funds, obviously, for this very important issue for the state of Texas. But the ARPA funds, those are essentially dried up this session, correct?
There will be some potentially in the supplemental and the, as I understand things, and the extension, but those are going away,
yeah,
basically. And we'll need to fund these now, if it's the desire of the legislature, to fund those with GR. And the ARPA gave us a unique opportunity to try things.
Yeah.
And the ones that I'm bringing forth are the ones that we thought were valuable. The ones that looked to us weren't, we've cut those off. And we are trying to bring the ones that the evidence in our eyes, peri-pan, workforce development, et cetera, are the ones that we have laid out before you.
Absolutely. Thank you so
Collaborative
much.
managed care.
Yeah. Thank you.
Thank you.
Vice Chair Gonzalez?
Thank you, Chairman. Ms. Leto, thank you for, thank you all for your testimony and all the work that you do. Imagine if we didn't have you all doing this work in the state of Texas, the gap that would exist for so many people in our state is really critical, so thank you. I have some questions building off of Representative Kitzman's questions and Representative Howard's questions on pages 8 and 9, specifically about the wait list. So a couple of questions around the wait list. The numbers, the things I'm hearing from local communities and the numbers seem a little bit different. So what is the data source for the wait list numbers?
That would be based on when we get a referral. Someone is referred to us needing the inpatient stay. So we maintain that wait list based on, typically it's a judge that would order someone into our care, and so that we maintain that list.
Is there a possibility that there would be a discrepancy in the wait list, like the locals might have a certain number and then you might have a certain number and there might be a gap that still could exist?
I think there's a possibility based on people who are waiting in jail but haven't yet been ordered by that judge to us. Mm-hmm. So that is possible. And we do not, we have some information on who it would potentially be there waiting to have that judge court order. But clearly your sources are better than mine on that number.
Oh, no, I'm not making any assumptions. I'm just making sure I have the accurate data.
Yes, ma'am.
Of the waitlist folks, do you have any data on how many of them have are IDD identified?
We do have a separate wait list for folks that are waiting for SSLC. We have, and also our state-supported living centers are where we can serve, as you know, folks with intellectual developmental disabilities. We have seen an increase in forensic need, so that dual diagnosis that you're talking about. We have currently 169 individuals that are pending admission. So many of those we're working through their applications. 91 of those 169 are forensic, and the rest are civil at 78. And also I will add that some of those are also youth.
Okay. And are these numbers included in these pages 8 and 9?
Those numbers are not. The 8 and 9 is just our state hospital side.
Okay.
But I'm happy to provide you the more information on our supported living center side, which would be the co-occurring.
Yes, if that would be helpful. I think
Yes,
that as we tackle trying to think about wait lists and who needs things, having a full picture, and I think some of the intersections of identities do start to play out in some of these numbers. So then help me understand, what is the average time of people on the wait list?
So for the wait list that I mentioned, I have that whole, 1 second. I have the number of days. So for our non-maximum security unit, people are waiting 189 days on average. For a maximum security unit, folks are waiting an average of 233 days.
Does staying on the wait list longer make it more difficult that when they finally get services to have them have the services for a less amount of time, if that makes sense?
Yes, it does make sense. There certainly is a concern for diminished health while waiting for a mental health bed. I know our jails do their best and do partner with some hospitals, and do work with us on when we can come in and try to help with restoring folks' competency faster so they're not sitting there. So we do have that in an attempt to get those folks what they need faster. But that is certainly an excellent point.
And so once they restore competency, do we have any data of how many folks are maybe put back into the system and then have to go through the same process over again?
I don't have that in front of me, but we should have that, and I'm happy to get that to you as soon as possible.
Because I think that's also an important data point for us to make sure what we are doing is working, and so it actually has a turnaround system. So then once competency is determined, is there a step-down program, or is it just, okay, back into the jail or back into something else?
But once competency, we try to restore that competency so then folks can go and have their time in court. What we absolutely have for folks that are staying with us, this is 4 forensic patients that are with us for a longer stay and are ready to transition to the community, or our civil patients that are ready. We do have step-down programs. Our hospitals run several, and y'all funded, we're grateful for that, funded our ability to expand that program last session. And then we also work very closely with our local mental health authorities on discharge planning. So the step-down programs aren't available statewide, and probably wouldn't meet every single need, but we absolutely try to get folks those services as quickly as we can for step down.
And so Representative Howard talked a little bit about diversion programs, but are there more things we could be doing on the front end so that we don't have a wait list that we have right now?
Dr. Lake, you may have an opinion on that too. We absolutely, and our programs are geared towards what can we do in the community before jail or an inpatient hospital stay is necessary, whether that's with us or a private bed. And so our community-based services for children and for adults are where we hope people will come when those mental health issues are starting to present, and we can work to avoid jail or an inpatient stay. So those are the jail diversion programs. But for youth, a lot of that is wrapping around the family with things like multisystemic therapy. But absolutely, the legislature's investment has been to gear us absolutely towards doing our best to avoid jail.
Thank you. Thank you, Chairman.
All right. Representative Harrison.
Hi. Thank you, Chair. And thank you all for being here. Commissioner, good to see you. I know we've gotten to spend a little bit of time together since I got elected a few years ago, and we certainly have some backgrounds in common, given that I did have the privilege of spending years helping lead the United States Department of Health and Human Services for President Trump, and so I have a deep and profound appreciation for both the responsibilities and the challenges of the job that you've got. One, and just so everyone knows, I'll save some folks some suspense while you and I could be here till tomorrow talking about the intricacies of federal healthcare policy and state healthcare policy and the interplay between the two. I will spare folks. One of the things that I do want to ask you about, though, is an issue that for the first time in maybe a generation is getting a lot of headlines at the federal level, is this issue of waste, fraud, and abuse, and taming, or I should say regulatory restraint, where it's needed, and it's needed a lot of places. And certainly it was true at the federal level when I was there. I mean, we were the behemoth. The U.S. Department of Health and Human Services is far and away the biggest government agency, not just in America, but on the planet, 2x the size of the Pentagon. And you, at the state level, you're the lion's share of the budget.
I am. Yes, sir.
You and the schools. So just a couple of questions. One of the things that I found really helpful during the first Trump administration that we did is we took very seriously the responsibilities came with being the custodian of, best we could estimate, around 20,000 regulations, is to sunset those regulations. And it took a long time to do it. It was a very hard process, but we did do that. I was really pleased when I learned a couple years ago that the state legislature, I think in the late 90s, instituted a statutory retrospective review requirement roughly every 4 years. So
Yes.
I just kind of want to ask you about that, because I do think my experience at the federal level was that there's massive cost savings that can be realized through retrospective review of regulations, and actually regulatory scholars on both sides of the aisle have commented on this for decades. Do you know roughly how many regulations y'all have at the state level?
We actually do have that number,
Okay.
but I don't
Not
remember it off the top of my
tip of your
head.
tongue, yeah.
I will say a couple of things. We are in compliance with the requirements for the four-year rule review.
Okay.
But I wanted to
You
mention...
don't seem too surprised that I'm asking you about that.
Well, I actually wanted to mention a regulatory reform initiative that we started
Great.
last year. We are in the process of looking, as you know, we regulate facilities and certain other groups, long-term care, acute care, child care.
Yep.
And we do some of our work in common with the FPS. So we are undertaking a review of all of our regulations. We started with kinship care in part because that is a vital component in the DFPS system. Parents, grandparents, aunts and uncles being able to take care of children in the system were subject to the same rules essentially as anyone in a foster care home. And so in the process of review, we went line by line, and we've reduced from 332 rules to 56 rules, so pretty significant. And what we did was we looked to see if you are a grandma who's taking care of a child, your grandchild, would this be common in her household? Okay. And so trying to take common sense, looking really at the health and safety and what really is required for health and safety, as opposed to something that might be an impediment for someone to be doing kinship care. Those rules will be final in the fall, which is very exciting. We're also looking at all daycare rules, because again, daycare, childcare is a huge driver for economic development in the state, and so we're going to be looking at those. We're looking at long-term care. We've already started end-stage renal care and chemical dependency. So we're actually very excited about this initiative.
Great. I would love to kind of follow up with your office on some
Absolutely.
of those once those rule makings go final.
Absolutely.
Would appreciate that. And I really appreciate you letting me know that your department is in compliance with the 4-year retrospective review.
Yes.
Do you have, and if you don't have it all available this morning, I would understand it, but do you have any sense that you're able to relate to the committee the results of those respective retrospective reviews, primarily in terms of like what kind of cost savings did they result in? How many regs were edited, modified as a result of those reviews? How many were rescinded altogether. Do you happen to have a sense that you could relay to us here
I don't
today?
have right now, but
Okay.
we can get you what we had.
Really appreciate it. And the reason I
Certainly.
ask is there was a legislative effort 2 years ago to strengthen that extant statutory requirement to simply preclude enforcement of regs that hadn't been subjected to that. And I don't think it was unique to you, but there were multiple state agencies, although including HHSC, that did submit rather large objections via the form of fiscal notes and others, saying that, well, the way I understood it, and I can follow up with you guys as well, but was that to come into compliance, it would necessitate, something like $50 million over some number of years, which would be very counterintuitive if the reviews were in fact happening as they had been required for 30 years or so. So any idea on how the reviews have been going in terms of quantitative or qualitative
I'll have to get
changes?
numbers for you.
Okay.
But I'm happy to do that.
No, I'd love
and
to.
we can come and talk to you about it as well.
Great. No, would greatly appreciate you following up with me on that. Do you have processes in place at the federal level? There's a lot going on at the Federal Health and Human Services Agency, and there was during President Trump's first term as well, on contract reviews. And every day we're hearing announcements of major savings coming from termination or other types of suspensions of contracts at the federal level. Is there any effort right now or any initiative in your department to do similar types of reviews on the contracting side?
We do contract amendments on a fairly regular basis. I can't think of an example off the top of my head. I know we oftentimes do look to see, do we still need something?
Great.
But I would have to get back to you.
Okay. Would you be open to following up with my office on
Absolutely.
some of those types of initiatives? I'd love to see Texas, quite frankly, take the lead on. I think we're well positioned given how large we are relative to the other states. And then I guess finally, Governor Abbott issued two recent, I guess one was an executive order and one was a direction to state agencies, one regarding
Yes, sir.
DEI and one, I think, recognizing the scientific and objective reality that there are two sexes. How is your state agency doing in complying with those? Or maybe I should rephrase it. What steps are you taking to ensure compliance with those gubernatorial directives?
Certainly. When the EO was issued, we took a look at our agency, and we found a couple of instances, several instances of the advisory committee appointments that I make that had some requirements in it that were not required by statute and were not in compliance with that EO. We are changing those. And where it requires rule changes, we are doing that.
Okay, well, would love to follow up with you guys on that as well, because
Yeah,
I
absolutely.
do appreciate you very much taking prompt action on those gubernatorial directives. Okay, one follow-up question then that may or may not be related. Dr. Lakey,
Yes, sir.
you mentioned, and I'm looking at an org chart here on page 4,
Yes, sir.
the Texas Child Mental Health Care Consortium. On the nonprofit side, because this is where we are seeing, not just in Texas, but across the country, lots of issues with these joint ventures, federal public-private partnerships, and things like that. Lots of cause for concern. There's three, if I read it right, there are three nonprofit organizations that are explicitly listed here, Meadows Mental Health, Hogg Mental Health, and Texas Council of Community Centers.
Yes, sir.
Are these the only three nonprofit orgs that are part of the consortium, or are there other nonprofit organizations?
These are the three that are formally part. The statute says that there will be three selected by the HRIs, and these are the three that were selected.
Great, thank you. What is the financial relationship between the consortium and however you want to call it, but the government, the state government, and these three nonprofit orgs through the consortium? Like, is UT funding these orgs? What's the nature and flow and directionality of the funding?
The only one of those three that has any dollars that have come from the consortium is Meadows, the collaborative managed care. When that was brought to the legislature and was asked for funding, that was part of the expertise is at Meadows, and so they go to the HRIs and help with that rollout.
So the other one, so Meadows did receive tax dollars. Are you saying that Hogg Mental Health Foundation and Texas Council of Community Centers did not receive tax
Not through
funding
us.
at all?
Yeah,
Okay,
yeah.
not through y'all.
Not through us.
Okay.
Yeah, and so we are looking at a pilot with the local mental health authorities to see how we can help with handoffs.
Yeah.
But my understanding is there's no financial component of that at this time.
Okay, so it's just it's a relation. The nature of the relationship is simply, I guess the statute directs there to be one, and then you consult with them. Y'all discuss. There's nothing more than conversational relationships between y'all.
Yeah, so they are on the executive committee, and so they attend all the executive committee members or meetings. But the three is. The statute says 3, and so we have 3 individuals.
Are there any state resources going? You mentioned one, Meadows. The answer is yes. But for HOG or for the other one, Texas Council of Community Centers, are there any state resources of any type going to those organizations?
So the HOG, I can't speak on their behalf.
Yeah.
So there aren't any funds through us. Okay. I know the HOG Foundation, it's attached to UT Austin, and that they work, and the local mental health authorities work very closely with HHSC for a large component of their funding, but they do not receive dollars from me.
From y'all, okay. Okay, I appreciate that. I would love to follow up with then, I guess, the most appropriate person within the UT system on that, because there's some highly troubling stuff on, in particular, the HOG Mental Health Foundation's website, where they explicitly attack duly enacted statutes from the legislatures from last session. In particular, are anti-DEI statutes, the gender modification procedure statutes, criminalization of drag shows for children, that they are explicitly hostile and oppositional to those on their websites. So it is very important to me that we make sure that no state resources are funding organizations that are then attacking not just that tax dollars aren't being weaponized against Texans and their values, but that the state of Texas isn't funding organizations that are at open warfare with our statutes, especially the statutes that are designed to protect Texas children. So we'd love to follow up with you or the most appropriate person of the UT system.
Happy to talk to you.
Great. Thank you, and thank you, Chair.
Okay. Representative Simmons?
Thank you, Chairman. So I have a question about serving as many Texans and children as possible with real substantive care. So wanted to kind of go back to the school district relationships. How are those enacted? How are they marketed? Are the school districts contacted? Do they reach out to you? Because I'm wanting to kind of get to why some may participate and why some don't. Yeah. And I was a student in high school, my senior. I had to use services, and it was a teacher that identified, and there was a relationship, and my parents, my family were lucky enough to have resources for me to continue that care. But I do think about some of my peers who would have benefited from some similar support at that age, but was misdiagnosed, unrecognized. And so I want to make sure that we are making these programs as widely available as possible. And if there's ways that we can do better, reaching across and saying, hey, this is a good thing. Is it a capacity issue? Is it, concerns about being nitpicked by the state and not wanting to, open themselves up to that type of abuse or concern? I just would like to hear more about that.
Great question. And so we have a variety of strategies to reach out to the school districts, beyond just sending emails. And so people send emails and follow up, et cetera. We work with the educational service centers, and you'll see on the organizational chart that there is a box now related to having somebody from a rural educational service centers, because the legislature thought it was important and directed us to put that box there, and they've been very helpful. We work with TEA, and you'll see in the box, the farthest box on the right, that we added TEA to our group in order for us to partner better with them and to get some of that help. But sometimes, Representative, it takes people just to go out and knock on doors. And so the people up in El Paso, in a rural area, they've done road trips out to small communities and knocked on the doors, both on the pediatricians and on the schools, and just to meet them and establish that personal relationship. And then once people see that there's a real person there, then sometimes they get them enrolled. But
You're speaking my language as an organizer. I love that.
Yeah. So they've tried various ways, and we're open to other strategies, but educational service centers, TEA, the going out, knocking on doors, introducing yourself, the emails, follow up. There does come a time when we have to say we have really tried hard to get this school district in, and we're just going to have to classify them as declined right now, because we spent a lot of time trying to make this free service that the legislature has generously made available available, but they have not taken us up on that. But we always tell them that if you decide later that you want to be part of this, the door's open, and we'll bring these services, but we need to concentrate on other aspects, even though we've done all this work to try to reach you. Does that make sense?
No, it does. Thank you so much.
Yeah, thank you.
And I really appreciate the work y'all do to make sure that Texans have access to care with as little nonsense as possible.
Thank you.
Right, Representative Kitzman?
Thank you, Mr. Chairman. One follow-up, you've hit on it a couple of times already, but when it comes to our local mental health authorities and the money they were receiving from COVID money that obviously is going away, I looked through the LAR. I didn't notice anything to kind of replace that. Did I miss that, or what do you think we ought to do about that? And because the need's still there, that didn't go away, and we know that there's still more to come. So, but do we need to work together through this process, or what do you think about that?
Yes, sir. Many of the programs that we put in our LAR and put in the some of our exceptional items are programs that would be run by local mental health authorities. And so we certainly depend on them as our provider for a lot of these services. Some do open up beyond local mental health authorities to contract for particular services, but they're fundamental to our community mental health safety net.
Okay, but where are we going to get the money?
We're happy to follow up with you and have conversations about, and we're happy to share data and anything we can to help inform your thinking and decision.
Well, I look forward to that visit. Thank you very much.
Yes, sir. Thank you.
Representative Manuel?
Hello, good morning. Most of you know how much I love rural Texas. So my question really is pertaining to that is, if you all have the data or an estimate, how far are people in rural areas driving to get to services, such as if you have to go to Houston or Dallas or San Antonio or any place like that if you're further out?
I can't give you a number, but it's a long ways. You
And
know,
like I know for us it's about two and a half
Yeah.
hours depending on where you are in East Texas.
Yeah,
It's longer for other people.
You know, if you're in Nacogdoches or Lufkin, we now have additional capacity in Tyler, but that's
Yes.
still, Tyler is still a several-hour drive to get there.
And I'm glad you brought that up because some of my colleagues do make fun of me for it when I tell them, I was like, yeah, people have to come to the big city of Beaumont to get health care. They're
Yeah.
like, Beaumont?
Yeah.
And it's, because people don't realize if you're in Orange and you're pregnant or you're in any kind of health crisis, it can take you 30 to 40 minutes just to get to a hospital because there aren't any services there for pregnant women and anyone else. And wondering, are there reimbursements for families who, if they have financial difficulties and they're trying to get to a mental health provider, that they can apply for that through Human Services to see about that?
Off the top of my head, I am not aware of specific programs that have transportation reimbursement. Commissioner?
Well, if a child is eligible for Medicaid, for example,
Then
there
they
is
will-
medical
okay, that's what I
transportation
thought.
that is available.
Okay.
Non-emergency medical transportation.
But other than that, it would just be, of course, at the expense of the parent or guardian to make sure that happens.
Yes.
Or the child gets to that appointment. If they can't afford the travel, then they just can't afford the travel and they would be without this. Not putting it on you all, but of course, if they can't afford it, then they miss that procedure.
I would assume that is accurate, although I do think you all have funded some mobile.
Right,
mental health
yes, to that
services.
get out
Yes,
there,
sir.
and that's been very, very helpful. And then lastly, just to say, thank you so much for the facility in Beaumont, especially to all of my colleagues. I know sometimes you don't always see things in real life, but the paramedics in our area sometimes are almost in tears because they're saying we don't have to drop these people to the sheriff's department in a few years, and we just keep telling their families, just hold on a little bit longer. It's gonna be okay. And it is so much appreciated because we do service Jefferson County services more than just Jefferson County. There's 7 to 8 other rural areas. People as far as Jasper have to come to us and even further. And so it's just so much appreciated. And thank you so much for your hard work. We really, you don't know how much you've uplifted our community knowing that we have a place that we'll be able to send people. So thank you so much.
Representative Tepper.
I have to wonder why we're so committed to diversion from jail for the chronic homeless. I think to any passive observer, it's not working. They're diverting from jail to programs where they stay for a day or two and they're back out on the streets or camping and they're a danger to the public. And I have to wonder how long and are we going to keep doing the same thing over and over and having the same results of just this toxic civilization on the streets of our major metropolitan areas. Jail is the only place they have to conform to treatment. They're safe from each other. Certainly the public is more safe. And I keep wondering why we keep being committed to this diversion policy that I think to any passive observer is not working.
We're happy, Representative, to take direction or guidance from you and work with you if you want us to look at other types of programming or change some of the programming that we have now. I'm very happy to
I think we need to look
you.
at a change in attitude on this because we keep doing the same thing over and over. It's not working. They're back out on the streets. And it's been a terrible problem that we can't seem to wrap our arms around. Even if the treatment or they're not going to be healed or cured from addiction, I think we need to prioritize our compassion. I think we need to prioritize the public and their safety and the use of their public places and the use of their parks. I think what we've been doing here in Texas and nationally has been just a mitigated disaster. And we need to approach it from a completely different perspective and approach. So I would be happy to meet with you. Let's get with staff and talk. But I looked at the bail reform that we're going to be doing this session that's going towards murderers and things, and it got off the rails of what I was trying to perform. With these, what were essentially lower level, maybe I should say higher level misdemeanors, but it's been just a revolving door, and I think we need to see bail reform on that scale. And by the way, my sheriffs aren't happy with my opinions here, but I have seen in some counties where they are treating folks from the jail. Because releasing them, they're not conforming to the agreements of the release and disappear again into the woods where it's just been that revolving door. And I think we definitely need to look at a different approach. So thank you.
Yes, sir.
Representative Collier.
Thank you, Mr. Chairman. I guess anybody can answer this question. I think the last time I checked, it's not a crime to be poor. Is that right? I didn't see that. And it's not a crime to have a mental illness. Is that right?
That is correct.
Okay, thank you so much. So I want to make sure that I understood your response to Representative Harrison's question, because he did ask a very fair question about what you are doing, HHSC, in response to the governor's directive. I want to make sure I understood the question, though, because I'm not sure if he was specifically referring to the directive to remove any provision that addresses diversity, equity, inclusion. Is that what you understood the question to be?
It is.
All right, and so then your response was that you reviewed some of the policies. You've been reviewing them to make sure that you're in compliance, of course.
Ma'am.
And then you said there was some language in the advisory committee appointments.
Yes, ma'am.
All right, was anybody relieved of their jobs or their appointments as a result of your review?
No, ma'am.
Okay, so in terms of your diversity, equity, and inclusion, you said that there was some language that you think it was related to that directive?
Yes, ma'am.
All right, and what were the words that were used?
It depends on the advisory committee. I can get a list of all the advisory committees and all the language that we reviewed.
Okay, and when you are looking at that, those terms, are you looking at people who have a disability as part of diversity, equity, inclusion?
There would, so in our advisory committees, there are statutes, and for some committees that require certain slots for people with disabilities, for someone with a mental illness, and we are trying to make sure that our advisory committee appointments conform to whatever's in the law.
Okay, so veterans also would be also part of the diversity, equity, inclusion.
Depending on what is in the law, and
Is that right?
Depending on what is in the law.
Okay. And so I also want to know if you understood, because there was some colorful language that was used referencing making sure that you're eliminating certain provisions and programs. And one of the terms that was very colorful was open warfare. Is that defined in statute, or do you have a definition of it that you understand the question? I just want to make sure, because the question was, are you going to remove language or remove those doing business with those entities that have declared open warfare? And I want to know if you know what that means, so that way we have an understanding.
I don't recall that.
That was one of the languages that was referenced, open warfare on, making sure that the state doesn't do business with those entities that have declared open warfare. And I just want to make sure we understand, because if you're going to be asked to do something, you want to make sure that you understand the assignment.
I don't recall that part.
You don't recall that
Sorry.
question?
No.
Does anyone else
No.
recall that? No?
Okay.
Okay, well, why don't you watch the video and come back, and then when you finish watching it, come back and talk to me after that. Thank you.
Absolutely.
I'm happy to clarify a question. Follow-up question to my question.
What's that?
You have to be ready.
Okay. We'll come. Representative Orr.
Thank you, Mr. Chairman. My question has to do, first of all, thank y'all for being here. Your website is amazing. And I've been on it, and I've noticed that some of your services, they are offered to charter schools. Is that correct?
The Texas Child Mental Health Care Consortium, yes.
Okay. Is there anything that would prohibit from y'all offering services to a homeschool child or a private school child?
We have prioritized first the public schools. There are other schools that have other mental health services, but we've told our folks that if one of those other schools requests services, that we would work them in to be part of the, to get services.
All right. Thank you very much.
All right, Representative Manuel.
I just had a quick follow-up question. If someone is incarcerated, are they forced to take mental health medication?
Unfortunately, I don't know the answer to that question.
Okay,
I'm
and I'll
sorry.
follow up with that one. But once a person, let's say they leave a facility, whether it's through Health and Human Services, whether it's they're incarcerated, can we force them outside of wherever they are to take medication, like in their own personal time, if they receive that? If, like, let's say I have schizophrenia, if I'm on the street, is there a way for the state to force me to take that medication?
Not that I am aware of in our programs and services.
And so do we deny people services if they don't take those medications?
Absolutely not.
And is it also a fact that sometimes people stop medications because they think that they're, I don't want to use the word, okay, they think that everything is they're back to normal. And so they stop the medication not realizing they could be doing more harm, or they are doing more harm to themselves?
Medication management is tricky, and that could potentially be one of the reasons that someone would say, I feel better, I can stop. But particularly if they're in our inpatient care, we try to work with them on what the best course of care is for them.
Okay, and also, is it true that I should ask, how often, let's say out of a scale of 1 to 5, how many times can it take a person to find the right medication that works for them while they are trying to go to work or just, trying to just be a person every single day?
That I don't know the answer to, Representative, but I can certainly ask our smart clinicians in our system and see what we can't get you for an answer to that.
So sometimes people are, let's say, sometimes people are just outside and they're in the throes of, I would say, a brain health emergency, and it may just be because the medicine's not fully working on them, or they thought that the medicine was fine, or there could be a shortage. So sometimes people are in the throes of a mental health episode just because of a broad list of things that could happen to them. It's not just because they just want to be violent and wreak havoc and, play games of thrones outside on the street with people.
Certainly making sure that that's one of the things our local mental health authorities do prioritize, is making sure that when folks come in, they're on the right medication and understand what it means to adhere to that course of care.
Perfect. Thank you so much.
Yes, sir.
All right, Representative Goodwin. Okay, no worries. All right, Representative Simmons.
Thank you, Mr. Chairman. And just wanted to circle back to homelessness diversion. And I appreciate my colleague, Representative Collier, for getting clarification on the criminalization of homelessness. And kind of what we were talking about earlier with Representative Wiley saying that Harris County Jail is kind of essentially the largest mental health institution in the county. We know that there's an increased need for mental health professionals. And we're here acknowledging the gap in the services, and you've made us aware of the need. But additionally, our proposed version of the budget, we are trying to increase pay for correctional officers, and CUD, CJA, and counties are trying to do the same thing because we know that there's a strain on our system. So would you say that a better use of state funds would to be not only just to handle homelessness, but for those who are experiencing homelessness and mental health issues would be to develop some treatment programs like the ones you previously discussed?
I'm happy to answer that question. We're happy to provide information on the types of jail diversion programs we have now and some of the outcomes that we're seeing from those. I'd certainly be looking to y'all for the direction on what you would want to fund further or expand, and we're happy to provide any information that would be helpful.
Yes, we'd love to follow up with you on that.
Yes, ma'am, absolutely.
All right, Representative Rose.
Thank you, Mr. Chairman. I just want to clarify a question that Representative Manuel asked as it relates to forced medications in state mental health facilities. Ms. Alito, patients can be forced to take medications in state mental health facilities. That's one of the reasons when patients, especially those who are found incompetent to stand trial, when patients or individuals are in a jail setting, you can't force Medicaid because they don't have the skill set, the correctional officers or the team do not have the skill sets, and that's why they're ordered to go to a state mental health facility where they are able to treat and correctly force medication. So I'm not for sure why it is that.
I'm sorry if I misspoke, but I'm happy to make sure that we're getting you the right information. I apologize if I misspoke on that point.
Oh, well, I don't think you misspoke. You just said you didn't know, but okay. Thank you.
All right. Representative Harrison.
Thank you. I just want to offer a point of clarification since it arose in one of my colleagues' questions. At no point in time did the executive commissioner receive a question from me or anybody else on the dais that used the terms open warfare. The context of that phraseology was in a question directed towards Dr. Lakey regarding the funding of external organizations and had nothing to do with HHSC at all. But while we're on the topic, I have copies of both Governor Abbott's, one is an executive order, one is a gubernatorial directive. Commissioner Young, did you read the words veterans in either of these documents? in the context of men or women who were soldiers, sailors, airmen, Marines, or Coast Guards?
I do not recall the exact wording on either the letter or the EO. I apologize.
But you don't have any memories of them referencing American veterans?
I'm not saying that it didn't. I just,
It's okay.
I never like to testify on something I can't absolutely
And I have
say I understand the language.
I have a profound amount of appreciation for you taking that position. I can tell you, since I just read both of them again, the word veteran is not in there, nor is the word disability. So just to make sure, HHSC, as a result of both of the governor's recent directives, you are not taking any adverse actions towards any Texans who are veterans or who are disabled. Is that correct?
I would never do that.
Thank you very much for the clarification. I do want to follow up with you on one, just because I want to make sure all state agencies are complying, not just with the letter, but the spirit of the directives, because I would love to follow up and make sure that you mentioned multiple titles are being changed. I want to make sure that the intended changes are actually manifesting themselves, and it's not simply like titles or renamings or things like that. Would that be okay if we follow up with you on that?
Absolutely.
Great. Thank you so much, Commissioner.
Representative Wu.
Just last time we put into the budget, I think around something like $4 billion for additional mental health facilities around the state. I think there were about 4 or 5, I think 4 facilities. Is there an update on how that's going, how the process is going?
Sure, absolutely. Representative Wu, we are on track for construction for those facilities, and I can, there's some of the timeline here, but I'm happy to meet with you and give you more detail. But we have almost fully implemented the community-based services investment and are well on our way to completing construction on time.
On all 4 units, or?
4 units, I'm
We'll
sorry.
follow up later. Thank you.
Okay, I apologize.
Yeah.
All right. I think that's all the questions for this panel. And our next, we're going to take up Medicaid. So I believe the commissioner will be staying with us.
Yes.
But we'll be joined by Valerie Mays.
All right. Mr. Chairman, I want to thank you for the flexibility on the agenda. And I want to introduce Valerie Mays, who is our Deputy Medicaid Director, who's filling in for our sick Medicaid Director. And again, thank you so much.
And this presentation, members, is on page 24.
Yes. Also, I have Trey Wood, our CFO, who will be joining us. And so take it away, Valerie.
Thank you, Commissioner. Mr. Chairman, Madam Vice Chair, thank you so much for inviting me this morning. My name is Valerie Mays, and I serve as the Deputy State Medicaid Director at the Health and Human Services Commission. I'll be starting on page 4 of the slide deck because I believe the Commissioner gave some opening remarks for the last panel. So what is Medicaid? Medicaid is a jointly funded state and federal health care program that provides long-term care services and supports to certain groups of low-income individuals. It also provides acute health care services in the Medicaid program. We also provide services in the Children's Health Insurance Program that is also a federal state joint funded program. CHIP is not an entitlement program, so it varies a little bit from Medicaid, which is an entitlement. I want to note on slide 5 that there are individuals who qualify for both the Medicaid program as well as Medicare, which is a federal program for individuals. We do have some folks that qualify for both Medicaid and Medicare, but HHSC does not administer the Medicare program. If you turn to slide 6 in your packet, we are currently serving 4.3 million Texans receive services through the state's Medicaid program. This covers a large number of total Texans in our state. It covers approximately half of births that occur throughout the state, a percentage of our children, and a large number of individuals in nursing facilities. I believe that the percentages listed on this slide will be providing you an amended update to make sure that they are correct. If you turn to slide 7 in your packet, who's eligible? So federal law requires certain populations and services be covered by the Medicaid program. It also gives flexibility to states to cover additional populations and services. So for example, there are financial criteria. how an applicant's income qualifies for their family group compared to the federal poverty level, which is set by the federal government for their annual household income. And so, for example, on the next slide, I'll talk through what those income levels are. And then there are other non-financial criteria that are taken into account to qualify for Medicaid. It's age of the individual, are they a child or an adult, their residency status, they must be a resident of the state of Texas, citizenship, alien status, and there's some other factors. The populations that are covered in Texas's Medicaid program are children and youth, their parents and caretaker relatives, pregnant and postpartum women, individuals age 65 and older, and children and adults with disabilities. If you turn to slide 8, there's a graph that shows the income levels that Texas covers for these individuals in Medicaid. The blue bars are the federal minimum requirements for Medicaid coverage, and the gray bars on your printed sheet show what the state has opted to do. And so you'll notice for eligible pregnant and postpartum women, as well as infants, they're covered up to 198% of the federal poverty level. For our children, a lot of them from ages 1 to 5 are covered up to 144%. As children age, they're covered at a lower level to 133%. We also cover a very small portion of parents and caretaker relatives of children that are receiving Medicaid services. We have individuals that qualify based on being medically needy. We have individuals that receive federal disability, and so they can qualify based on their disability status. And then we also cover certain long-term care services and supports for certain populations. To give you an idea of who qualifies based on this calendar year in 2025, for a family of 3, it's approximately would be $2,220 a month for their child to qualify for Medicaid. On slide 9 of your presentation, we were asked to provide an update on House Bill 12 from the last legislative session. House Bill 12 requires HHSC to provide Medicaid for women who are eligible during their pregnancy to receive 12 months of postpartum coverage through the state's Medicaid program. Previously, it was 2 months of postpartum coverage. And so this required federal approval, and so we went through a process with federal partners, and this was implemented on March 1st of 2024. One of the key things to point out is that women continue to receive the same full benefit package from the time that they were pregnant into their postpartum period. And so this can include things like hospital stays, lab visits, any specialists that they need to see, mental health services. Their full array of Medicaid benefits are available to them. In addition, this coverage is also provided in our children's health insurance program. If you turn to slide 10 in your packet, this is a very high-level snapshot of what Medicaid covers for most individuals. So coverage is provided for acute care services. This is preventative care, diagnostics, lab services, x-rays, those types of things. Long-term care services and supports support someone with ongoing activities of daily living for an individual with a disability or an older adult. So this can include things like cleaning, helping them get in and out of bed in the morning for an individual, helping them bathe, supporting them in living in the community. We also cover behavioral health services, screening and treatment for mental health conditions and substance use disorder. And so this can include an outpatient visit for counseling, for example. Medical transportation services, you heard the commissioner mention this on the last panel. And so if something that is not an emergency and they need assistance getting to and from a Medicaid appointment, scheduled visits, they have access to a transportation service to pick them up and take them to their corresponding appointment. And then there's also coverage for prescription drugs in the program. If you turn to slide 11 in your packet, there are 2 primary service delivery models for Texas's Medicaid program. We have managed care and fee-for-service. And so if you look at your slide, 97% of individuals in Texas on Medicaid are currently in managed care. That has been at the directive of this body over the last maybe 2 decades, I think, where programs have been rolled into the managed care service delivery model over time. And so a managed care organization is paid a capitation rate per member per month, and they are required to deliver the full array of Medicaid services based on that individual's qualification into Medicaid. They negotiate rates with providers. Providers sign contracts with them to serve in their program, in their managed care plan in that part of the state. And they can also provide value-added services, which are paid for not with Medicaid dollars, but by the managed care plan. And so a really good example of a value-add service I like to highlight is that plans may provide a car seat for a pregnant woman in order for her to be able to take a baby home from the hospital. We also have the fee-for-service program that clients may go to any provider who is enrolled in Texas's Medicaid program. They submit claims directly to a contractor that operates our claims administrator program, and they're paid per unit of service. So they're paid a rate that the state has established through our rate setting process. Most fee-for-service clients don't have access to our service coordination benefit. That is something that is at the crux of our managed care service delivery model. If you turn to the next slide, you can see the different managed care programs that Texas offers to individuals. Our STAR program is our program that's primarily for children in Medicaid, pregnant postpartum women, and some families. STAR Kids is our product line that is focused on children and youth with disabilities. So these are a lot of children that qualify for federal disability or children with complex care needs. They are enrolled in the STAR Kids program. Our children's health insurance program is a very small portion of who's in our managed care programs. And so these are, again, families who make too much income to qualify for the Medicaid program based on their family's income. STAR Health serves individuals in Medicaid who are involved with our Department of Family and Protective Services, who may be in state conservatorship, and so the youth coming out of those programs. And so that is one specific product for them to ensure, regardless of where their placement is around the state, they're being served by a single managed care organization. And then STAR Plus serves adults with disabilities and those who are age 65 and older. And so for the individuals who qualify for both federal Medicare and Medicaid, they're in our STAR Plus program. I do want to note that dental services are also provided in Medicaid for children in CHIP and in Medicaid under the age of 20 years old. And that's done through some dental managed care organizations. And if you turn to slide 13, it's very small on a printout. We do have this available on our website, but this outlines our managed care organizations, where they serve across the state today by product line. And so this is information that's also available on our website. And so that's the prepared update I had for you on Medicaid, and I'm happy to take questions.
All right, Representative Gervin Hawkins.
Thank you, Mr. Chair. My question focuses around what I call low pay and slow pay for our Medicaid folks, particularly our doctors. What is the root cause? Is it because of lack of staff, processing of paperwork? How can we get those payments move a lot quicker?
Are these payments for providers who are in the MCO networks?
Yes.
Is that, okay.
There are requirements around how quickly the managed care organizations are required to reimburse providers after they've submitted claims. And so I don't have that in front of me. We can get you that information. And then always, if there are issues or challenges that providers are having, our agency is constantly following up with oversight activities to ensure that providers are getting paid in a timely fashion.
And offline, can we visit? I have a bill out there. It's called low pay and slow pay correction that we really need to figure out what we can do to correct, because there's doctors still waiting on payments that are 2 years old.
Yes, ma'am.
Thank you.
All right, Representative Rose. Sorry.
I didn't turn it on, but I do have a question since it's on. Thank you. You gave a brief update of HB 12, but do you have any numbers of how many women are being covered or any type of information regarding outcomes?
And so what we have available, Representative Rose, is currently the average caseload that we've gotten from Trey's team, so he's welcome to jump in, has been about 268,000 women. Now this group includes both pregnant women and postpartum women, and so we've kept them in the exact same program. And so before the PHE existed, we had approximately 140,000 women in the Medicaid pregnant women's program on an average monthly basis. And so we do know that we've seen a shift in the caseload during this time period. I think our team of forecasting folks would say, I think we're still waiting to sort of see what and how enrollment will settle out between last year's unwinding efforts and then implementing House Bill 12 to get a better understanding of what that caseload will look like.
Oh, you look like you have something to say. You have something to add?
No, Valerie covered it very well, but I think kind of to boil it down, basically that average monthly caseload is about 130,000 more as a result of HB 12.
Okay. Well, thank you. When you all finish your final analysis, could you all make sure that our office it's my office and Representative Howard's office, because you see how she stood up when she heard me mention that. So it would be great if you all could get us that information.
Yes, absolutely.
Yes, ma'am.
All right. Representative Wally?
Thank you, Mr. Chairman. First of all, thank you, Representative Rose and this House for passing HB 12 on the 12-month extension. So I do want to acknowledge the work that she did and this body did to get this done. And I'm talking about, and Representative Rose briefly talked about utilization, but as I understand it, hearing from providers, is utilization down or up currently?
It's too soon to tell.
Okay.
And so there is a lag in claims data that comes into our
Okay.
system through our managed care organizations. And so there's about an 8-month lag. We are absolutely interested in and will be looking at what the data is showing us for access for these women.
Right, because part of the, as mentioned in previous panels, the Maternal Mortality Review Board Committee, the number one recommendation is always access to care, right? And so this folds into that continuity of care to get these pregnant moms the care extended out to the 12 months. And there's other avenues. I know that the legislature passed, I think, Representative Hull's bill on doula services and expanded reimbursement on doula services. Is that something that we're also trying to incorporate into not so much but implementation of HB 12, but just in general access to care for pregnant moms?
I believe you're referencing House Bill 1575.
Correct.
Where the agency was directed to have a screener for pregnant women to understand their needs, both it could be while they're pregnant or postpartum, and we have an obligation to report out on the outcomes of that information. And so that screener went live on September 1st of 2024. So we are actively collecting information, and our first batch of data was just due from the managed care plans on January 30th of this year to give them some time to get their data submissions. And so we will be looking at outcome information, and so that will be information that we will actually be reporting back to the legislature.
Yeah, that'd be helpful just in general, based on that information, but just in general, in talking to some of the providers, the utilization, as I understand it, is could be better in making sure there's continuity of care for the pregnant mothers. I wanted to talk to the agency about the Medicaid unwinding, and it's my understanding that during the Medicaid unwinding process, that the agency temporarily implemented income-related process changes for administrative renewals. Is that correct? Sorry, I apologize for that.
That's okay. If I understood your question, during the unwind, did we disenroll people based on income? Is that?
Well, I guess the question is, during the unwinding, that we were allowing TWC data to help them in either extending the coverage or dropping folks off. So I'm just trying to figure out how in the unwinding, how we would have unintended consequences, like kicking folks off that probably didn't need to be kicked off. So we used some TWC data is that my understanding?
I'm not aware of any specific problems that we had because of incorrect TWC data. Clients, members also had the chance to submit information, and they had a longer grace period to do so during the unwind if we got it wrong, and we needed to correct income employment.
Right, so was TWC income data used in the unwinding?
I would have to get back to you on specifically what data we got from TWC. I'm more familiar with what we get from them on the SNAP side of eligibility,
Okay.
but I can certainly let you know.
Okay. And then on the Medicaid procurement process, I know there's been some issues on the contracting and the way the agency implemented some rules regarding the procurement process. And what I'm getting at is, as certain entities were awarded contracts or not awarded contracts, I'm concerned about the continuity of care as some folks were changed providers.
Couple of notes. I'm going to be a little bit limited on what I can say, just because we're engaging in litigation. We believe that the procurement was clean and fair procurement, and I believe at the end of the day will prevail in this particular lawsuit. I think there may be some misunderstanding of continuity of care.
Okay.
Usually that has to do with a client being ensured that a client continues to work with their provider for 3 months past the transition. There's some other continuity of care issues. I think some people may have believed that when people switch plans, that constitutes a break in continuity of care, but that is not how the statute or procurements work.
So there's no gap in coverage between
no, sir.
the change? Okay. And so if a family that's on the program needs to see a provider and then there's a change, they'll be able to see that provider?
For a period of time until they can, for a period of time, yes.
Okay, but what do you mean by a period of time?
So again, I need to be a little bit careful about talking about the procurements, but
Well, I'm just saying in general then,
Yes.
right? So if there's one provider was the historic, I guess, provider of a particular family, there's a new provider that comes in, where's the gap? How long do people have to wait to see their doctor when there's a change in provider?
we have requirements, but I don't remember what it is off the top of my head.
Okay. There were reported data breaches regarding the SNAP. Did somebody address that?
Yes.
Yes.
I can. So absolutely, we did have a data breach. One thing I will note, typically when people think about data breaches, they think about external parties going in and seeing, having access to our information. In our case, we had some employees who changed PIN numbers and looked at Social Security numbers. And so that is the data breach that you're referring to.
Correct.
We found it in November. We've done our notifications to our clients at that time. We believed around 61,000 people data was breached. So
Okay.
it's terrible.
And these were internal staff.
Yes, sir.
Has there been an effort to reach out to you said 61,000?
Yes,
Okay.
sir. We sent letters of notification to those clients.
Okay, and then what is the action plan for those 61,000? I mean, what did we tell them?
So we gave them access to credit monitoring, and that they have in their letters they have I think it's Experian. Thank you. I think it's Experian, and they will be able to use that free of charge for 2 years.
Okay. And then has there been an effort to, do we have any confirmed, reported, I guess, victims of any kind of impropriety where somebody's information is used in a nefarious way?
I have not heard of anything to that effect.
Is there an effort to try to recoup? Were there any funds that were misappropriated?
So we do believe that there were some benefits that may have been taken.
Taken from people that,
Yes, from their cards.
so internal staff
So
stole
stole
recipients,
change PIN number. Yes,
and these four folks' money was taken from them?
not.
Or how does that work? I don't know. I'm just,
We are aware of I think one notification that we got from a client that said that funds were taken. So
okay. Do we,
that funds were taken.
okay. And
I believe that's the right number. One, yes.
okay. And so all these folks, I understand, have been terminated.
Yes, sir.
Okay.
And just so you know, we have the benefit of the Office of the Inspector General. That's something that the legislature has funded for a number of years. And they have tools to investigate fraud, and in this case, they are involved and are providing law enforcement assist.
Okay. And then is the agency spending any dollars recouping some of the SNAP benefits
From the
impacted clients?
impacted.
Like from folks that stole these dollars, how are we, like obviously some dollars were stolen, is that correct?
Yes, sir.
So what are we doing to recoup those stolen dollars?
So again, I believe this is all part of the law enforcement side of the world.
Okay. Okay.
Or the Office of the Inspector General may also have something. Unfortunately, once it goes over to him, I have less visibility of what is happening on that.
I get that. Can you talk to us about it? I'm gonna switch gears here.
Okay.
So, are we working to try to implement summer EBT?
So a couple things about summer EBT. As you all know, this is a brand new program. I think sometimes, can you hear me? I think sometimes people believe that it is SNAP, and while it does provide some SNAP benefits, it really is the National School Lunch Program, and it has 3 agencies that are involved. So our agency is involved, TEA is involved, and the Department of Agriculture is involved. We need to have you all designate a lead agency on this. No single agency has any of the data, the complete data that needs to be compiled in order to do a summer EBT program. And so we do believe that we are going to have to get funding to implement. One of the things I'll mention, I think, when this was set up in rule, in the final interim rule that passed, it's a very convoluted way it was set up. Honestly, it requires a lot of notifications and some due process issues, but also an exchange of information that is not currently exchanged. So we, for example, don't have access to school data. So we believe that in order to get started for summer of '25, we need to know that y'all are going to fund it by March 10th.
Of this year?
Yes, sir.
Okay. So do you need a statute to tell you who the lead agency is,
So-
or is that requirement by the federal government that you designate a lead agency?
We can't designate the lead agency, but the state would need to designate the lead agency, and then We do not believe we need statutory authority. I cannot speak for TEA. I do believe they have told us they believe that they need statutory authority.
Okay.
But I'm not an expert in their area, so you will need to talk to them.
And have y'all met the three agencies?
We have been talking extensively for the last year.
When's the last time y'all met?
Oh, gosh, I don't know.
Regarding
back to
summer
you.
ABT?
I'll get back to you. I
Okay.
really don't know, but we've been meeting, as I said, extensively.
So if the legislature would want to fund summer ABT, we would have to designate the lead agency by March?
You
Or,
would
I'm
need to
sorry,
designate
maybe-
the lead agency, but we would need to know that we're going to get the funding.
Oh, you need to
do
know
it
that
by
the funding will be
March.
there, okay.
Correct.
March
10th.
Do we have an idea of how much, because there's some startup costs, right?
There
You
are.
need staff and you need to be able to exchange information between TDA,
Yes.
TEA, and the commission,
And
or
the-
the agency.
And the federal requirement is for a separate database. So our anticipated cost for startup is, and then there are some ongoing costs, is about $110 million. That's an all-funds number. It's at the roughly 50-50 match. I can't speak to what TEA or Department of Agriculture's costs would be.
Could you, those startup costs, could those dollars be reimbursed by the federal government since it's a
Again, it's a 50-50 match.
50-50 match on the startup? But
Yes, so-
as it's implemented, how does that,
The benefits themselves are all federal funds.
correct, and
Yes.
that's where I was going, so
Yes.
you beat me to it.
Okay,
Um,
sorry.
They're all federal funds, and so these startup costs wouldn't have to be necessarily continued. These are just dollars that you have to put in now.
Some
But
of
as
the-
the program ramps up, it's almost primarily paid for by the federal government.
Some of them, though, would need to continue. For example, the notifications that I mentioned, while that sounds like it should be small, there are up to 5 notifications we have to send to each family, and that is actually the bulk, very
Of the
large
cost.
percentage of the
Right, because you're gonna mail some
That's
4 or
correct.
5 pieces of.
At different points in the process.
Right.
Yes, sir.
Is there a way to get waivers to try to minimize the dollars? You know, the letters, the postage, the 5 notifications?
So-
Could we like text people or?
I do think we can ask
Yeah.
people for texting. They have to opt in to texting.
Right.
So,
Okay.
Yes, sir.
And do we have an idea of how many families qualify?
we think there are about 3.7 million kids, I think, that would qualify. And about 890,000 of them would have to go through an application process. The rest are streamlined.
So right now,
Number.
the kids that are on just free or reduced lunch that fill out the application through their child nutrition programs and their ISDs, is that the data you're talking about to try to get?
I
Because you
believe
got to do the
so.
outreach, right?
Yes, we do have to do outreach, but they have to do it. I believe TA would also have to do it.
Okay.
I'm sorry, I'm don't really know a lot about their processes,
Okay.
so I don't want to miss.
I'm just trying to,
Yep.
make it easier for for whoever's going to be the lead agency to help them streamline the process so that
Yes.
these children get fed in the summer, right? Because ultimately, summer EBT is about feeding kids in the summer. I think that's how I
It's
understand.
$120 for the summer per child. Yes,
Right.
sir.
And so they get kind of, as I know other states have implemented this, they get they get a card
Yes,
for the
sir.
child. The
Yes.
family gets a card per child,
Per child.
and they get to buy food for the summer, correct?
Yes, sir.
Okay. And so over 3 million children
3.7, yes, sir.
would qualify.
Yes.
How much would that be in dollars back to the state of Texas?
We believe, I think it's, hold on, I was trying to look and see what I think it's
50.
50, something like that.
450 million.
That sounds right.
That's my number. Okay. Okay, thank you so much.
certainly.
Representative Howard?
Thank you, Mr. Chairman. I'm looking at slide 8 on Medicaid income eligibility levels, just to clarify. The medically needy who qualify, you have down here, they have to be at 15% of the federal poverty level, which, if I have the right number here, you have it down as $275 for a family of 3 a month. That's a family that makes $3,300 a year for a family of 3, correct?
Yes, ma'am.
And just to clarify too, when we're talking about Medicaid expansion, that's the category, I guess, that we're looking at, right? Those that are adults that don't fit into any of the other pockets. They're not pregnant, they're not disabled, they're not over 65. It's those poor Texans. And the expansion would cover up to 138% of the federal poverty level. So again, with this same family of 3, that's only $36,800 a year. And we have about 1 million Texans who would be eligible. I'm just clarifying, is that correct?
I don't have in front of me, ma'am, what the numbers what the estimate would be for Texans up to that income level.
But that's the correct, that's what we're talking about when we're talking about it.
Federal level
Very
to expand,
poor
ma'am.
people, yeah, okay, thank you. And then in terms of on the next page, when we were talking about a Medicaid for pregnant women and the postpartum coverage, I'm very thrilled about what Representative Rose and the legislature was able to do last session to expand that from 2 months to 12 months postpartum. I wanted to ask you though, you have to be eligible, you have to be pregnant. Do y'all have any kind of numbers about when do women typically access the program and when they are, I mean, obviously they have to know they're pregnant. They have to apply to find a provider. Do you have any concept of how far along they are in their pregnancy when they finally get coverage?
I don't have that information in front of
Do
me.
y'all have that somewhere?
I believe that we have
Okay.
information based on what trimester they come in on, because we have requirements in Medicaid about how quickly we have to get them in for a prenatal visit, and the
Yeah.
plans have contractual requirements based on what where they are in their pregnancy.
Okay, I would appreciate that information. Thank you so much. And then I know in the summary of HB1, the supplemental for Medicaid for fiscal 2025 is $750 million. That's what's in the summary. So what I'm wanting to know about is how much of that is cost containment that was assumed and budgeted for, but we weren't able to achieve, or how much of it is medical cost growth, caseload growth?
Yeah, so good news on that front. Ultimately, we're not going to have a Medicaid supplemental need for this biennium, in large part due to higher than expected experience rebate revenues that we received. So there's not going to be a Medicaid supplemental need.
That's pretty unusual, right?
Yes, we actually had that for the first time ever in 2021, large part due to COVID and the PHE enhanced funding. I told everyone under sun that was the only time I would ever report that information. I have successfully been proven to be a liar, but I'll be able to report it again in the 25th session.
Does and your reason for it, but does some of it have to do with the unwinding and people not getting coverage?
No, it doesn't have to do with that.
Okay.
It has to do with during the public health emergency, we set rates for Medicaid on an annual basis, but the way the PHE worked was extended coverage on a 90-day basis at the federal level. That doesn't really work with a rate setting model that you do on a yearly basis. And so to combat that or to properly account for that, because you can't really do it on a normal rate setting methodology, the commission adjusted the contract experience rebate threshold levels that are in the contracts with the MCOs to capture a higher percentage of that rebate, because we knew that it was likely going to generate excess profits. And so we accounted for that, and that it takes time for that to come in and then for Medicaid team to process that. And then so as we're going through and doing that now, it has generated higher revenue than we would have otherwise received. So in essence, we kind of prepaid for Medicaid expenses.
So no supplemental.
Yeah, exactly.
Okay. Also then looking at the funding for the women's health programs. Okay, based on an LBB forecast, both for the 24-25 base and the 26-27 recommendations, that forecast differs from y'all's projections, from HHSC's projections. So for example, For 2027, HB1 has a caseload of about 19,500 for family planning clients receiving services. The HHSC LAR has caseloads of 25,900 for that. HB1 has 27,000 for Healthy Texas Women. The HHSC LAR has 51,300. So I guess part of what I'm trying to figure out here is if HHSC is not spending the 24-25 appropriation, what are the barriers for full expenditure and how can we address that?
So I think there's a couple of things at play. Obviously, we've talked quite a bit about HB 12. Instead of women exiting the Medicaid program and rolling into Healthy Texas Women or the Women's Health Program, they are now staying in Medicaid.
Okay.
So certainly for 24-25, you're definitely seeing lower than expected both caseload as well as expenditures because of HB 12, which I think is kind of the intended impact of that.
Yes.
Where this will ultimately settle, we just don't know yet because you've had 4 years of basically policy changes at both the federal and the state level that are impacting Medicaid. We have to see where that settles out and how that ultimately then feeds into the Women's Health Program, which is kind of comes after the conclusion of a number of women's eligibility in the Medicaid program. So we don't exactly know where that's going to settle and probably won't for a couple of years, honestly, as we get back to normal and start seeing what that permanent caseload is going to be in both Medicaid and then the Women's Health Program.
So we won't know for a couple of years, but I assume that there will be some benchmarks along the way while we're in this next couple of years where we'll see which direction we're going so we can make sure that we're funding appropriately.
Oh, absolutely,
Yeah.
yes.
Okay, thank you very much.
Yep.
Representative Garcia Hernandez.
Thank you, Mr. Chairman. Thank y'all so much. I know I've seen a lot of y'all over and over again, and thanks for getting our office up to speed on the nuts and bolts with the Medicaid system and the EBT summer program and also the data breach. In regards to the data breach, and I know that we had kind of discussed this before, but is there a way that representatives can be informed as far as reasons we can't know the exact individual, but the number of constituents that we have that have been impacted by the data breach?
We can get that for you.
And I think I have not asked my fellow colleague's question he wanted me to ask on his behalf, but also, as far as your inpatient Medicaid reimbursement rate for hospitals, do y'all happen to know that off the top of your head? Or is there somewhere where we can locate those reimbursement rates for facilities?
Are you talking about for like just in general or for psychiatric type care?
Psychiatric.
For psychiatric type care, I believe it's around $528 per day. It's within $10 of that. I just can't remember the exact number.
Thank you. And also, is there a place where we can locate that information for reimbursement rates today based off what the treatment is? And
yeah, we include a number of rate tables that we post online with what the current rate is, as well as what it would cost to do like a 1% rate increase. So then you can calculate, whatever the percentage would be above that. We can share that link with your office and provide that information. Not a problem.
okay, thank you so much.
Yep, absolutely.
Representative Harrison.
Thank you, Chair. Thanks again for being here for the questions and taking questions. My memory on this is a couple of years out of date, but I know at least as recently as I think it was 2020, the improper payment rate for Medicaid was in excess of 1 out of every $4 expended. Now, these are, of course, national level aggregate data, but over 25% of Medicaid payments were improper payments at the federal level. Do you have any idea, do we have state level data on improper payment rates here in Texas?
I think that would most likely come from the Office of Inspector General, as they're the ones that do the investigations into the fraud, waste, and abuse aspect of it.
Yeah, can I follow up with you guys on that one, though? Okay. Do you think they've got it, though, at the state level annually?
I hate to speak for them.
Okay.
I mean, we can certainly coordinate with them and get information back to you on that.
Great. No, I would appreciate that. I mean, as I think all of us probably on the dais take our fiduciary responsibility to taxpayers seriously. I know you on the other side of the dais, I'm confident y'all do as well. And it's very important, or program integrity is something in our Medicaid programs, both in Texas and, of course, nationally, given my previous role, is something that is a great consequence and something that I think all appointed and elected officials that have custody over these programs put paramount significance into. Because we got to make sure that the folks who are receiving these dollars are the folks who truly need it. Every improper payment is a dollar going to somebody who, by definition, is not needed the program. And I want to make sure that these dollars, when we're taxing Texans, they're ending up in folks, the pockets of folks who truly need it, and not folks who don't. And states have a lot of tools at their disposal. You know, as y'all know well, screenings on the front end, screening on the background, not taking a simple unverified attestations. Post-enrollment reviews. There's a whole panoply of options that y'all have. Are y'all able to talk about any of your recent program integrity efforts and any savings that have resulted from them?
A couple of different things I would mention. Again, we're extraordinarily blessed to have the OIG that goes after fraud, waste, and abuse. And if we hear of anything that sounds fishy or is reported to us, we refer to the OIG. Additionally, we work with the AG's office on civil Medicaid fraud. I don't know of something just off the top of my head, but we can go back and look.
Yeah, if they
I know we do a lot of work. We look at eligibility. We have some external ways of trying to review eligibility to make sure that people are qualified to receive the services.
So in Texas, for a lot of those criteria, it's not simple attestation. Is that correct?
That's correct.
Okay, good. And yeah, I would love to follow up with them if you don't mind.
Absolutely.
Having them reach out, because I just want to make sure, because there are multiple things proactively the states can do. For example, increasing the frequency of post-enrollment evaluations and interviews, that sort of thing. Since it was mentioned a second ago, actually by multiple of my colleagues up here, the notion of unwinding. I think everyone's referencing the result of the federal COVID PHE terminating, and the fact that Texas, as well as the vast majority of states, took the federal government up on their offer of I forget the number, but I think it was 6.2x FMAP in exchange for an agreement on disenrollments. Has there been, I know we're out of that now, but was there ever an analysis done on sort of the net cost or net benefit to the states? In the early months and years of that, it obviously was a financial net benefit to Texas and probably every state. But we stayed in that state of a PHE where we took the deal, 6.2 FMAP up, disenrollment's gone, for a protracted period of time. Has there been an analysis by HHSC, OIG, or anybody else that have said, hey, look, over during the entire pendency of that deal we made with the feds, on net it cost us X, or it on net financially benefited the state? Do we know?
Yes, sir. We absolutely did do that.
Because there was a break-even point. I thought at one point we broke even and pushed through into the net coster side.
It broke through. There was a decision point in terms of are we still continuing to receive a benefit, or we started eating into some of the prior benefit that we received. So overall, and I'm speaking specifically for the Medicaid program, yes, we did save money for the state by opting into doing that over the course of the public health emergency. There's no doubt about that. We did eat into
qualitatively, it was a net benefit over the entirety of the program.
For Medicaid, yes. I'm speaking very specifically about the agency and the Medicaid.
Yeah, and if I wasn't clear, forgive me, my questions were specifically state Medicaid.
I just don't want to speak about the state at large because
I'm only asking you about your programs.
Yeah. Absolutely, fair question. So yes, we have looked at that. We actually have that posted online. We can send you the link of the analysis that we've done.
Yeah, I'd love to see, because I think about 2 years ago we crossed the break-even point from being a saver to a coster, and I never knew the aggregate.
So, but we never crossed into being a coster. We just, instead of, we reached that point where we were no longer generating additional savings. We were eating into some of the savings that we already. So we still net benefited the state, or net benefited the Medicaid program. It just, we didn't generate as much as we could have.
There's a chart I'm remembering. It was you guys. It was about 2 years ago. I would love to just revisit that with you offline.
And we've got it posted online.
Okay, good. Thank you very much. That would be super helpful. On HB 12. This was a SPA, right? Not a waiver request. It was a state plan amendment, right?
That's correct.
Okay. And did you say it was adjudicated in Texas's favor? Was it March 1 of 24?
The effective date of the benefit started on March 1st.
Effective date.
Our state plan amendment was approved in January of 2024. I don't have the specific date in front of me, but I'm happy to provide that to you.
Month and year is what I was looking for. I couldn't remember when they adjudicated it. But just to be very clear, this was the Biden-Harris administration that adjudicated that SPA request. Is that right? This was not the Trump administration, right?
Correct.
Okay, thank you. And I would love to, if you don't mind, add my name to my colleagues who've requested the financial data as a result of the increase or that Medicaid expansion. And to go back to, I think it was you that made the point of, if I wrote this down right, about 268,000 total women in that program from 0 to now it's 12. Used to be 0 to 2. Now it's 12, up from 140K average. Were those numbers right?
Yes, sir.
And did that start after the prohibition on disenrollments that arose out of the COVID PHE, or was some of that, or were there still disenrollments happening during this period? Because what I'm trying to get at, is it a simple calculation of 268 minus 140, or would the 140 have actually gone lower as a result of the PHE ending, and then you got to add back on to the 168, to the 268?
Yeah, so I think that's kind of a complicated question to answer, only because what I referenced earlier was, you had 4 years, I think roughly 4 years of not being able to disenroll anyone out of the Medicaid program. So you had changes at policy at the federal level, changes at the state level, dissecting what, we can see where we were prior to, we can see where we ended up. We're backing into kind of what that difference represents. We can't sit there and parse out specifically, well, this piece is related to this piece of federal legislation, or this piece is related to this piece of state legislation. It's very difficult to get the nuance of
No,
what
and that's
the
why I'm
impact
asking
is.
the question. I made no assumption. I make no assumption. I didn't know whether you had the data or the granularity of the data to be able to say this variable caused this downward decrease versus this one, which caused this one upcrease. But it would be fair to say that it's not just as simple as saying it's 268 now, it was 140 before, and so you can just subtract that, get a delta, and that's the change, or that's the impact. Is that right?
That's what we're doing in essence to say the net impact of all of that changes is that 130.
Right, but you're doing it of all of the changes,
That's-
though. So I'm just saying it wouldn't be fair to say that you had this number, now you've got this number, and this one thing happened, therefore it's all a result of HB 12, right?
I don't think we could say that it's all the result of HB 12.
Yeah.
There's just too many things that occurred over a 4-year period for us to be able to definitively make that.
Nope.
specific
And that's
statement.
the answer. If that's the answer I was looking for. Do we have, given that those are Medicaid beneficiary numbers, and just point of clarification from my recollection of this when we were debating it in the legislature, they become from 2 months to 12 months, they become a full Medicaid beneficiary, right? This was not an extension, for example, of Medicaid postpartum. You are a full Medicaid beneficiary, right?
That's correct.
That's correct.
But
Okay.
during their 2-month postpartum period, they were full Medicaid beneficiary.
As
for
well,
women in Medicaid.
0 to 2, they were full Medicaid
Yes, sir.
beneficiary, and that extension of full benefits went from 2 to 12, right?
That's
Okay,
correct.
thank you. Do we know that we're around? I know you're back. It's a similar question but different. I know you're having to do back of the envelope math to get the number of beneficiaries per month, but do we have back of the envelope math on the cost of those increase?
I do. Let me see if I have it in front of me. And it's very back of the envelope because, again, we're kind of backing into a lot of things.
There's multiple variables that happened during that time.
So, again, very high level, rough estimate, but we estimate around 248 million GR that would have been the cost of that.
That's an annual number?
That's a biennial number.
Biennial?
Yeah.
248?
Yeah. So that's the number for this biennium. So it was, only partially implemented for 2024.
Yep.
So that's basically, 18 months of implementation. But again, that's at a high level. That's an estimate before we actually saw any kind of data of what we thought it was going to be. So that should tie back to the fiscal note that we had on the bill at the time.
Yeah, because I would love to compare that to the original cost
and so
projections
we
from
don't
2
have
years ago.
the actuals yet because as Valerie mentioned earlier, there's a data lag that in terms of the providers actually billing the MCOs, the MCOs paying, and then it gets reported to us. That's a naturally occurring thing, and so we won't have updated really good data until sometime next year.
And definitely not for discussions here, but I would love if you guys could follow up with my office on that changes in the rebate structure you negotiated with the MCOs, which is leading to us not necessitating a supplemental. That's great news on the surface. I just would love to dig in with you guys offline on that. One last question, because food stamps have come up a couple times. There was this is ancient history data, but one of my former colleagues who's no longer here, Representative Matt Schaefer, I know had done a lot of work on his concerns anyway of out-of-state utilization of food stamp benefits. And my understanding was at some point his office had discussions with HHSC OIG where they had agreed to look into the matter. And I know this is a very old issue, but I'm unaware of any actions that have been taken as a result of his findings, which I can send to you guys again. But are you aware, did HHSC OIG ever undertake any kind of an audit or investigation as a result of what he uncovered?
I don't know, but you might talk, I think y'all will be hearing maybe from the OIG. So if not, we can work with your office and the OIG and we can come talk to you.
Yep, would appreciate it. Great. Thank you. Thank you, Chair.
Representative Simmons?
Thank you, Mr. Chairman. So, just switching gears a little bit, want to talk about the human part of these services. So, full disclosure, I have a little bit of bias in this. When I worked for the State Employees Union, a big thing that we were against was kind of the decentralization of like your caseworker. When you received services, you typically went to an office in your neighborhood. You built a relationship. Those people got a chance to know you, and it's kind of your last line of defense as an impoverished person. As an impoverished person, to say, "Hey, these services are working really well," or "These services are not working well for me." Now that has shifted to where you can live in Houston and you pick up the phone to call somebody about your services, and that person may be in El Paso and they've never seen you. I know that was supposed to be a cost-saving measure, so wanted to know, like, how has that worked out over the years that this has been implemented, cost-saving-wise? Has it been effective? Also, what is the end-user result? Like, what is the human impact on that? How are we checking in with patients and recipients to say, hey, is this service working for you? Or as simple as, we noticed that you've missed the last 3 doctor's appointments. Is there a transportation issue? Is there something else going on in the home? I know that the agency's, capacity is what it is. We know that these, services are critically under-resourced, but when we're talking about and getting into the nuts and bolts of who's doing what and how much this costs, and, those factors are really important. But again, these are people at the end of these services that we should care about. I care about my constituents. My district has one of the highest rates of uninsured people, and so we know the threshold is very, very low. But for the people who are, actually able to obtain those services, many of them don't because the process is difficult. But for the people that are, a lot of them are not utilizing the services that they should, and we're seeing that impact. And so I know that was a long round of, around the world, but just want to hear a little bit more about the people at the end of those appointments and visits and services. Thank you.
Sure. Because we operate a managed care Medicaid program, we have a number of federal requirements to measure quality. How is it going? How are the plans upholding their contractual requirements? And so we do a couple of things. We do a secret shopper to try to obtain appointments ourselves through a vendor, where they call and pretend to be, X, Y, and Z Medicaid recipient to identify, can they get in? How long would it take them to get in? And are they successful at scheduling an appointment based on those specified time periods? And so we measure quality in that way. We're also required to do quality surveys of all of our Medicaid participants. The populations that we survey, it's a rolling basis that we get that data. That is data that's used, that's a federally required survey, and we use that information in our quality programs where the plans have not just a contractual requirement, but they're incentivized that if their quality increases, they can qualify for certain incentive payments. And so we also use that information to hold them accountable if they have specific things that we're hearing about. A third wrinkle is we look at all complaint data. And so HHSC has an Office of the Ombudsman that is run by counterparts, where they are the front door for anyone who's experiencing a challenge or a complaint. And we monitor and measure all complaints for the managed care organizations to ensure not just that that specific individual's issue has been brought to fruition, that we've resolved their complaint, their issue, their access to care, if that's their specific concern. But we also look at that information collectively, again, going back to their contract to determine whether or not we have remedies against them if they are not, in fact, following up with folks. So that this multi-plan structure of this quality program and our oversight is really meant to get at the heart, I think, of what you're describing, Representative, are the individuals who qualify for Texas Medicaid getting the care that they're entitled to in a timely fashion? And if not, how can we be working with our managed care organizations to assure that that's occurring?
And just to kind of follow up on my next question, I know that there's a lot of concern. Some of it, feels a little bit silly in like terminology we're using. I know DEI for some of my colleagues is a big concern, but there's a reason why we want to know, why certain demographics are experiencing one thing. And so when we're talking about maternal mortality, we know that Black women experience that at a higher rate. We have to collect that information. It's important, and part of the reason why they experience that is race. Or, for example, there are people in our state who may not English may not be their first language. And so to be able to, adequately provide services, we have to make sure that we have a number of, languages that are accessible. And so how much, if you can explain, has this kind of focus on, removing anything that, discusses differences in people made it harder for the agencies to be able to provide services for different communities?
I don't believe there's anything in the executive order that would affect at all the way we clinically treat people in our services. So the Medicaid program is required to provide medically necessary services for any of our clients.
Thank you.
So, you're welcome.
All right, members, any other questions? Well, thank you for being with us today. We appreciate what you guys do and the hours you spend answering our questions. So next on the agenda, we're going to hear from Commissioner Muth on the continued rollout of community